You just come and do the more effortless phase of breathing in. On him. You can apply PEEP, yes. So he's saying that portion on a ventilator, PEEP supplies this for you. All right, it just keeps the alveoli open for you. That becomes reserve volume. Okay, but in your body, that reserve volume just stays there. You cannot exhale it. Even if you try, you cannot do it. Okay, but if you have a disease, then it can collapse. Now you've lost reserve volume. All right, then the next volume is called expiratory reserve volume. This is the amount of air left in your lungs you can force exhale. That means you have to, that means at the end of exhalation, there's still some more air you can blow out. That's expiratory reserve volume. But you have to force it out. Notice you got to use all these abdominal muscles. Now more air can come out. Expiratory reserve volume is also part of functional reserve capacity. That means, Amy, it also serves a function. What is that function? To fill up your dead space, Halima. Fill up your dead space. What's the normal tidal volume for an adult, Halima? What's the number I gave you earlier? Was that? No, not 5 liters. Let me ask Anders, what do you remember? Not 6 liters either. All right, Nave. 6 to 8 cc's per kilogram was the number you need to know. Okay, you calculated. So expiratory reserve volumes, the amount of air you can blow, force exhale at the end of normal exhalation. But it takes a lot of accessory muscles, and mostly abdominal muscles. Any questions on that? Now, what function does it serve? Since it's part of functional residual capacity. The function, Halima, of expiratory reserve volume is to fill up most of your dead space. You understand, Halima? You understand what I just said? The job of expiratory reserve volume is to fill up your dead space. That means, Halima, watch my hands. That means when you inhale, you're actually putting a column of air up here at the top, but that pushes the same amount down here at the bottom. The air you inhale is up here. The air you extract the oxygen from is down here. It's not the same puff of air. You understand, Halima? You visualize that? What? You don't understand. Do you understand what my hinges did? You have a column like this in your lungs. When you inhale, you put it on the top like this. And it pushes the same amount down here. So the air you breathe in is not the air you're getting oxygen from. You understand that? You're just putting a pocket at the top and it pushes the same pocket down at the bottom. But your expiratory reserve volume. So your tidal volume is 6 to 8 cc's per kilogram. Let's say your tidal volume is 500. I don't see anybody in this room sucking in 500 cc's per breath. None of you are. The average person only sucks in 100 to 150 cc's. And they'll ask you, well, how the hell are they filling up their lungs? That's because you got dead space full already. Expiratory reserve volume did that for you. That way, all you do is put a pocket up here at the top, and it pushes the same amount down here at the bottom. That's why any column of air in your airway lasts a while. See that? Slowly going down to the bottom. So in other words, if I ask you, Halima, where is the freshest oxygen going to be found in your lung? Top or bottom? Top. Because when you inhale, it comes right up here at the top. The most stale oxygen is down here at the bottom. You understand that? Anybody not understand that? So that means if I look in your lungs, the most oxygen, Sabu, is going to be found at the top or at the bottom? It's going to be at the top because it just came in. The most carbon dioxide, found at the bottom. That just came in from the blood supply, arterioles. Everybody understand what I just said? I want you to be able to visualize it so you're not memorizing what I'm saying. Okay? You're inhaling, but it's coming and stacking right here at the top. That's because there's already a pocket right here that pushes the same amount at the bottom. So that means the freshest oxygen, top. Most carbon dioxide, bottom. A good way to remember this, why do you think TB likes to go to the top of your lungs? He ain't no fool, he Googled it. He ain't got no Google saying freshest oxygen, top of the lungs. I'm just telling you, that's how I remember all these years. Because it suddenly made sense to me. What? So TB goes to the top. Because he knows the freshest oxygen is up there. How come it's down at the bottom? But if you want to kill something in your lungs, where do you take them? Bottom of your lungs. Why do you think right or left lower lobe pneumonia are the most common? Your lungs try to move all the infections to the bottom so that they suffocate and die because there's hardly any oxygen down there. Everybody understand what I just said? That means the freshest oxygen enters top or bottom of the lungs. Top. Carbon dioxide enters top or bottom of your lungs. Bottom. So that means you're going to do switch. So the oxygen starts moving down to the bottom while carbon dioxide starts moving up to the top like this. See that? You got carbon dioxide receptors up here at the top of your lungs. When they suddenly feel carbon dioxide at the top of your lungs, does everybody understand? That means the whole column is carbon dioxide now. Everybody understand what I just, remember it's coming from the bottom, going up like this. So that means if they make it to the top, that means you got a whole column of carbon dioxide sitting in your lungs. You understand that, Sandra? You understand that, Mayha? So that's when your lungs say, you know what, you need to empty the whole thing out and refresh it. That's why when carbon dioxide touches the top of your lungs, it makes you sigh or yawn. A yawn is physiological, folks. Is to clean out your lungs, i.e. clean out your dead space and fill it with fresh oxygen. You understand that, Karina? Just talking about yawn makes you yawn. It does. It's the memory of it. But that means, Karina, if I'm that person and I suddenly yawn to clean out my lung, does everybody understand? I just released a ton of carbon dioxide into the atmosphere. That's why anybody around me who takes the next breath, all of a sudden carbon dioxide touches the top of their lungs. That's why you yawn after anybody who yawns around you. Sounds like physio to me, folks. Sounds like physio to me. See what I mean? Okay. It's when you think it's something always, it sounds like it's always something complex. I say, no, why don't you go back to the beginning and you see where they're getting this stuff from. Okay. Anybody that yawns, people around you will yawn right after you because you just exhale a ton of carbon dioxide for them to inhale. That means the next breath, carbon dioxide touches the receptors. They yawn. But because it's so beneficial, even if you hear somebody yawn on the radio, it makes you yawn. It's just like, no, just because I say yawn, you yawn. That's because even your brain knows the memory of a yawn makes you feel fresh. That's because it's fresh oxygen coming in. Okay? But anyway, I just want you guys to understand the physiology of a yawn. Yes, Anna first. The lower lobes of the lungs are the most prone to getting ischemia and the most prone to getting an infection. Lobar pneumonia, majority are down in the lower lobes. When you're doing shunting, the lower lobes are the first ones to shunt. That's correct, sir. Now you see it for yourself and you understand it versus I said it, you memorize it. All right. The bottom of the lungs has the most carbon dioxide and is most hypoxic. That's why pneumonia goes, your lung actually draws them down there. Well, you can suffocate them. Remember, bacteria need oxygen like you. So if you're taking away this oxygen, they die faster. But that's also why you get most abscesses at the lower lobe. See that? Because every abscess is anaerobic by nature. Well, that's where you're going to be anaerobic. It's down at the bottom. Okay. All right. So now we've done RV and extracellular reserve volume and FRC. Any questions for those three? Next one. Oh, who's speaking? Oh, Muhammad, go ahead.
So you said 3 to 5 cc per kg.
No, I said 6 to 8 cc's. Remember, it's already in your notes. You saw it earlier, 6 to 8 cc's per kilogram. But if you're doing restricted lung disease, 4 to 6 cc's per kilogram.
So if you lose weight, does that decrease your?
If you lose weight, no. That came up years ago. The actual tidal volume that they used to have was 10 to 15 cc's per kilogram. Till somebody asked the same question you're asking right now, Muhammad. When somebody gains weight, do they gain more lung? The answer is no. When you lose weight, do you lose lung? The answer is no. So they recalculate based on ideal body weight, which means that lung, that once you develop it, it doesn't shrink or swell. It's the same lung. 6 to 8 was what they came up with. That's less than half of what it used to be. All right, 6 to 8 is based on ideal body weight and ideal size of the lungs, Muhammad. So that's why
it's harder for. That's why it's harder to breathe when you're obese.
Yeah, that's why it's harder to breathe when you're obese, because you got all this adipose tissue sitting on top of the lung now.
Okay, perfect. Thank you.
Yeah, same size lung, but it's trying to move all this weight off of it to take one breath. All right, next one. Tidal volume. Now you know how to calculate it, okay? Then the next one after that is called inspiratory reserve volume. That means at the end of a normal breath, you can force inhale. How do you do that? All these accessory muscles up here. This is why whenever I say somebody's using accessory muscles, That means they're either using it up here to inhale or down here in the abdomen to exhale. Inspiratory reserve volume, the amount of air you can force inhale at the end of a normal inhalation. Okay. And then when you cannot inhale any further, we say you've reached total lung capacity. You can't go any further. TLC. Cannot go any further. So total lung capacity includes all the air that's in your lungs. Both passive and forcible inhalation is included. All the air that's in your lungs, even the residual volume, which you didn't have anything to do with, is included. That's why they call it TLC. Now, vital capacity is all the air you can inhale, both passively and forcibly. So that means it starts from residual volume, and then you can inhale all the way to TLC. That's vital capacity. How about all the air you can inhale starting from the starting point, which is FRC? Then we call it inspiratory capacity. So that's why you got to sit down and really look at this picture, and you can visualize the whole thing. If you can visualize it, like I said, all the questions are easy. That's what I'm telling you. You have to visualize this. That way you get ready for all these questions they're going to be asking. Okay? Now, 3 ways. I use 3 volumes to tell me restricted or obstructive. Again, like 99% accurate. I'll take it. There was one rare time they'll catch me. I'm okay with that. All right. Number 1 was residual volume. If it's elevated, you got obstructive. Decrease, you got restricted. I don't care how elevated or how decreased. Everybody understand? They start playing with numbers. 58%, 49. I don't care. If it's less than 100, it's decreased. If it's more than 100, it's increased. Okay. All right. Since RV is part of FRC, FRC is the other one. Same thing. If FRC rises, Halima, restrictive or obstructive? Obstructive. FRC drops, restrictive. Again, they'll give you a ton of information, folks. I'm giving you the 3 that makes your diagnosis for you. Get in there, answer the question, keep moving. Don't try to figure out all the other ones they put in there for you. That's put there to confuse you. But 3 numbers, 99% accurate. And all I need is one of them. I only need all 3. Okay? Next one. So we got RV first, FRC second, and then the next one is vital. Hang on. No, total lung capacity. Total lung capacity. If it rises, obstructive, drops, restrictive. You understand, Cynthia? You understand, Melissa? All right. That means even though they give you 10 to 15 numbers, folks, just look for one of those 3. You should already know that what kind of disease you're talking about. And if it's just a physiological question, you already know how to answer it. You don't need to know what disease it is. Take your point and keep moving. Figure it out some other time. Any questions on that? All right. Now, let's look at one other thing. FEV1 over FVC ratio. FEV1 is how much air you blow out in 1 second. That's decrease in both diseases. That's why by itself, don't use it. In restrictive, you took in less. That's why you blow out less. In obstructive, you can't blow out enough. Well, you blow out less. So FEV1 is decreased in every lung disease. Cannot tell me a thing. Next one, forced vital capacity. It's all the air you can exhale if I give you all the time in the world. They just say you blow out into a tube. And then we set up a ratio. Because both of them are decreased in every disease, just so you know. That's why you don't look at the numbers by themselves. You set up a ratio if they haven't set it up. Usually they've already set it up for you. So normal person takes in about 5 liters, blows out 4 liters in just 1 second. That means the normal ratio is 0.8. So you got to know that's your starting point. It doesn't start at 100%. And let's go to Solange. In obstructive, are you having trouble breathing in or out? Breathing out. So you're going to breathe out more or less? Less. So your forced vital capacity, let's bring it down to 4 liters rather than 5 liters. You with me? Okay. But in 1 second of breathing out, you're going to breathe out more or less? In obstructive? Less. So rather than 4, it'd be a 3. So now 3/4 is 75%. See, that is dropped from 80%. That's why, as long as you know the starting point is 80%, any number below 80, you got obstructive lung disease. So please don't look at FEV1 or FVC by itself. You get yourself all confused. It's decrease in both lung disease. It cannot tell you what disease you're dealing with. The ratio tells you what disease you're dealing with. And restrictive, Sandra, you're gonna have trouble breathing in or out. Huh? In. You're gonna breathe in more or less? Less. So let's say you took in 4 liters, less than 5, right? But you can actually blow off all 4 liters. Why? Because your alveoli will collapse. So 4/4 is 1. So it doesn't matter. We don't get up to 100%. The rule is, as long as it's above 80%, they'll just use 81. Good enough for me. It doesn't have to be close to 100%. The key is, if it's above 81, above 80, you got restricted lung disease. Because what you're telling me is alveoli are actually collapsing. Most of the air you took in is coming right back out. So you can use RV, FRC. So the lung capacity you can also use, and now you can use FEV1 over FVC ratio, not the numbers by themselves. Any questions on that? Okay, again, 99% accurate. And that way you can answer their question without even knowing what disease they're talking about. Unless they ask you what disease, fine, then finish reading the vignette because I need to know the clue. All right, there's all the volumes. All of them are defined for you. That's in words, but you got to be able to visualize it on that graph. All right, compliance and airflow through the lung. Lauren, your turn. Compliance starts at 0 when you first start to inhale. Why? Because alveoli collapse. And then you inhale. Look at that, 0 compliance if the alveoli collapse. That's not good. As you start breathing in, alveoli start to open. Compliance then starts to increase. When you get to 50% of breathing in, you got the most compliance. So the highest compliance in your lungs, airway, alveolus, however they want to say it, is always the highest in the middle. In the middle of breathing in or the middle of breathing out, doesn't matter. It's always in the middle. You understand that, Lauren? Does everybody else see that? Okay? So in other words, look at this. It's 50-50 here. The two numbers add up to 100. What if I ask you, where's the compliance the same as here, at 0? It's the same as at 100%. Whatever question they ask me, if they put a number on it, your answer, your number's got to make it equal to 100. So if you say, where's the compliance the same as when you're here at 30%, Mitchell, then it's 70% of breathing in. 40%, then it's 60% breathing in, and so forth. Everybody follow? The two numbers have to equal 100%, just like 50-50 equals 100. Just like here, 0 and 100 equal 100. The two numbers have to equal 100. That's where compliance is equal and airflow is equal. Well, let's go over to Meha. Meha, you don't want your compliance to be at 0, do you? No, that's severe restricted lung disease. Alveoli completely collapse. That means you don't have to work real hard to open up that balloon, which means that 75% of inspiratory effort I talked about, you have to supply it. This is the reason why, listen carefully, every restrictive dies before every obstructive. That statement is never false. That is because the minute you get a restricted lung disease, your compliance is near 0. You're going to have to struggle for every breath there is. I mean, look at a guy like Bernie Mac. He was only probably in his 30s or 40s. How come the guy died soon after he got sarcoidosis? Severe restricted lung disease. You're going to die before any obstructive lung disease. But you see COPD years in their 70s and 80s, and they've been smoking for 40 years. That's because they're lucky. Obstructives get to live a lot longer than restrictives do. Okay, but just so you guys understand the big picture. All right, so that means compare this disease, I already know which one's worse. Restrictive will always be worse than any obstructive. Everybody understand that? That way on the test, you're not starting to guess because they'll just pick 2 new diseases and answer the same question. Okay? All right. But that's why we don't want alveoli collapse. But look at this, though, Cares. I don't want your alveoli completely inflated either. That's called severe obstructive lung disease. This is why, listen carefully, they tell you every obstructive lung disease, long-term, called COPD, at a certain point in time, they start to behave like a restricted lung disease because their compliance goes to 0. They're completely inflated. They say, breathe in, Mr. Neal. Guess what? Now you're having a hard time breathing in. That's not the physiology of obstructive. That's because you're years, decades into this disease. Every obstructive At some point in time, starts to behave like a restrictive because their compliance goes to almost zero, just like restrictives. And that's why they start dying. So once we label somebody with COPD, why do you think they don't live long after that? Because they're fully inflated almost. That's why we don't want that. So how do we deflate them? That's why give them a beta-2 agonist to empty some of that carbon dioxide in there. That's why that helps. How about stop the inflammation? It's called steroids. Why do you think that decreases mortality? Treat the infections that are clogging up the airway. Why do you think antibiotics decrease mortality? See my point? Or how about a lung transplant? We'll just give them a brand new lung. There are 4 things that decrease mortality, folks. That's how I remember it. I always go back to the physio and back end for things. Because once they give me a list, I say, how did they come up with this list? Look at the physiology long enough, you start to, I see where they got it from. Now you can see it too. You don't have to memorize it anymore. But that way, when they give you a clinical, what are the 4 ways to decrease mortality in COPD? In my mind, I'll go right back to it. I say, oh yeah, that's right. How do you get the alveoli to collapse some? That means give it more compliance. Okay? So how do I know you have hit that point? That point is when you see barrel chesting. What are you full of? Carbon dioxide. And that lung is not collapsing. Okay, now you're COPD. You have barrel chest. And what do you see with that? Polycythemia. Why? Because now they're hypoxic. Obstructive lung disease doesn't have a problem with oxygen till the end. Because now they've lost compliance. See? All right, question. When surgeons are doing lobectomies, yes. How to save compliance, right? You try to take out the most inflated alveoli, because then that way you don't have a VQ mismatch anymore. The body doesn't have send blood to those alveoli. You just remove them. Yeah, that's how you save them, by covering out some of their lung. Yep. Spirometer. No, on the spirometer, just tell you about the different volumes. It doesn't measure compliance. Yeah. And inspiratory spirometer, this is just a little tube put by the bedside. The person just inhales and blows into. That way you can measure his pulmonary function right there at the bedside. Rather than doing a $500 test. Inspiration. Now let's put some numbers on things. Everybody follow me carefully here. Let's go to Maria first. When you inhale at the beginning, here's the chest wall. Let me zoom in a little bit here. Right hand, chest wall. Left hand, lung. You with me? When you inhale, chest wall goes out first. Where's more expansile forces? The who? Girl, you just said 3 things. Now, which one is the answer? No, then why am I pointing at the chest wall for you? Good Lord. So you guys think, no, he's trying to trick me. He's trying to trick. I'm trying to make it easy. I'm pointing right at the answer for you. And she said, no, it must be the other one. He's trying to trick me. Okay. If the chest wall went out first, he has to have more expansile forces. It's impossible for the lung to be the one that has greater. He would have gone out first then. You better understand. I'm just trying to show you guys how to make this easy. The chest wall goes out first. He has more expansile forces. In the middle of breathing in, also the lung starts chasing him. See that? So from 0 to 49% chest wall, 50 to 99% lung. At the end of inspiration, the lung was going out. Expansile force of the lung equals recall of the chest wall. And that's why forces are equal and opposite, no more movement. Remember, at the end of anything, 2 forces are equal and opposite. They'll just ask you, what 2 forces are there? At the beginning of inspiration, chest wall expansile is greater. 0 to 49. 50 to 99, chest wall expansile is greater. Why? Remember Bernoulli effect? You create a vacuum. Whoever's close to that vacuum, you got to move into it. That's what makes the lung start chasing the chest wall. At the end of inspiration, the lung was still going out. Expansile force of the lung equals recall of the chest wall. So the chest wall goes out first and recalls first. So when 2 forces are equal and opposite, movement stops. You understand, Sabu? Let's do the opposite now. Sabu, here's the opposite. They meet up right here. And now the chest wall will start pushing your lung in. Okay, that's like somebody pushing on you from behind. Pushing in like that. That means the chest wall has more recall force. Everybody understand that? And now something for 50 to 99, see that? If somebody's pushing you from behind, after a while, you have more momentum. You actually will move away from him. See that? Same thing here. Chest wall recall was first, and the 50% lung recall is greater. And then at the end of inspiration, the chest wall wants to go back out while the lung is still going in. And that's why they finish apart from each other. That way you have a vacuum for the next breath. Because if you don't have a vacuum, remember, you got to work hard for the next breath. So we don't want that vacuum to ever disappear. At the end of every breath, you recreate the vacuum again. Okay? So now, if you understood what I just said, so boom. At 13% of inspiration, which force is greater? At 13% of your inspiratory effort, which force is greater? What are the options? I don't know what two things were we talking about. There was only two things. It's either chest wall or lung. Then you got to say compliance, expansile force or recoil force. Huh? At 13% of inspiration, which force is greater? Chest wall or lung first? Chest wall, expansile or recoil? Expansile because we're still going on. That's why I made it easy. 0 to 49, 50 to 99. Okay? On exam, they pick a number out of the blue. I find that the number just makes students all of a sudden, they're crazy. They're nuts. Because they put a number in, now you panic. Oh, the book didn't talk about 33%. Who cares? This is what they're testing right here. If you know there's only 4 quadrants of all of breathing. And now let's breathe out. Look at that. Exhalation. See, 0 to 49, recoil of chest wall. 50 to 99, recoil of the lung. At the end of exhalation, recoil of the lung equals expansile of the chest wall. That's because they go in opposite direction. That's why they pull apart from each other and stay there. Now you're ready for your next breath. At 72% of inhalation, which force is greater? Count them. Lung or chest wall first. Lung, expansile or recoil? Huh? No guessing. There's the 4 quadrants. It's written for you. First quadrant is chest wall expansile. Second quadrant is lung expansile. All right, for breathing out, first quadrant, chest wall recoil. Second quadrant, lung recoil. That's it. What? I gave you 72% of inspiration. You're not recoiling during inspiration. Yeah, so it's got lung expansile. Any questions on that? Again, they'll pick any number they want. You got 4 quadrants, folks. They're all easy questions. Okay? Now let's put in some numbers. What? You know the example I just gave him? I gave him 72% of your inspiratory effort. Which force is greater? Yeah, greater. Lung or chest wall? Which one are you picking? I don't know what the middle is. There ain't no middle. I said lung or chest wall. What's this middle stuff? Is lung what? Expansile or recoil? That's my point. That's the same thing I just gave him. Yeah. It's 2-step method, but it only takes like 3 seconds. You got to decide, is it lung or chest wall? Who's greater in that quadrant? And then are we going out, expansile force, coming in, recoil force? As long as you're methodical, folks, you get them all right. If you start guessing or trying to remember what a book said, that's when students mess up. Because now you're not thinking it through anymore. You're just trying to guess what's the answer when they're really very easy questions. All right, now we're going to put some numbers on it. Baseline, Halima. That means before you breathe in, it's called FRC. The 2 volumes that make up FRC are. What's that? Now let me ask Melissa, the 2 volumes that make up FRC. Residual volume and? No. All right, Ashley. Residual volume and? Expiratory reserve volume. You can look at your diagram. Now I gave you a diagram to look at. All right, the key is stop guessing. I told you the brain loves to guess what the answer is, but I want you to know, how do you get that answer? Just look at the diagram. They give you the diagram on the exam, okay? So FRC is your baseline. If you look at tidal volume, starts at baseline, comes back to baseline. So FRC, RV plus ERV equals FRC. That means at baseline, your intrathoracic pressure at that point, Halima, still you, is -3, -5. That's the vacuum that you want before you breathe in. If you have a vacuum, you don't have to work so hard to inflate the balloon. They're already inflated for you. Any questions on that? So, Halima, what's your normal CVP? Sitting outside the right atrium, sitting outside the thoracic cavity. Normal CVP is what? What's that? I can't hear you. No, -3 to -5 is intrathoracic pressure. What is your CVP? Normal CVP. You learn that in cardiac. It's not in here. Melissa. What's that? No, 8 to 12. On them. No, not 5 to 8. Jess. What equation? I gave you guys a number for CVP. There was no equation. All right, Anders, what's the number CVP? 0 to 5, but the average is 3 to 5. Okay, why am I pointing that out? Your CVP is the exact opposite as your intrathoracic pressure. Physics. Why you have to learn physics for med school? Here's one. Saba, when two forces are equal and opposite, which way is there going to be net flow? 0. I submit to you another incorrect statement in every physiology book. They say that blood flow into your chest, into your heart, is continuous. No, it's not. If you know physics, when they're equal and opposite, blood flow stops. Everybody understand what I just said? Oh, if you want to argue with physiology and cardiology, that's the one that gets them. I said, I'm telling you, the books are wrong. How so? Okay, let me show you. That means when you inhale, remember I told you, why do you inhale with each breath? To make the whole thoracic cavity negative. That's why mine is 12. Okay, 3 to 5 goes in with no problem. So what if I make the intrathoracic pressure positive? Guess what? No blood goes into your heart anymore. How do I do that? What if I just put my hand around your neck and stop you from breathing in? How come all the veins in your head start being engorged? Because blood flow is not moving into your chest anymore. Why does the person die? Because blood flow didn't go into his chest anymore. That's why choking you. How about people at the bottom of a stampede and people walking over them? They cannot inhale. Remember I told you about the 21 people that fire in Chicago? All of them died because they were down at the bottom. People were walking over their backs trying to get out the door. And they all suffocated and died because their chest did not move the whole time. People, 2 of them, 200, 300 pounds on top of you, you're not going to be able to inhale. That's why they suffocated and died. How about if I make intrathoracic pressure positive by pneumothorax? How come all of a sudden you die? How about cardiac tamponade? How come all of a sudden you die? If blood flow in the heart was continuous, then this would not happen. See, another one the books got all wrong. They make it look like blood flow is always continuous no matter what you're doing. I say that's not true. Not if you understand physics. -3 to -5 equal +3 +5. There is no more movement. It stops. If you didn't make your thoracic cavity negative, blood flow would not go in. It is not continuous. It's just that the eyes cannot see it. But if you make the pressure more positive in the thoracic cavity, blood flow starts moving. Proves the point right away. Yes, Anna. Does this apply to Valsalva maneuver, meaning when you're grunting, when you're bearing down? Yeah, when you're bearing down, you're also increasing this pressure. That means blood can't go past it anymore. And that's why all of a sudden blood flow can't go into your heart, can't go into your lungs either. Yeah. When you take a tidal volume, look at where it is. See that? -10 to -12. See a 3 to 5 draws right in with no problem. When you take a deep breath, TLC, -20, -25. Now, these are the normal numbers for a normal person. That means if you know what normal is, Justin, on the test, they'll adjust it with a different number. So let's say they tell you a TLC, they have a -27. What does that tell you? They have what? But how did they get a more negative intrathoracic pressure? What? Well, we all inhale. How come his is minus 27? Mine's only minus 25. You're on the right track, man. So when it's slightly off, we say either you took a deeper breath or a slightly shallower breath. So if I gave you TLC and I give you minus 18, you say, oh, he took a shallow breath because it's just slightly below normal. Or a minus 27, oh, just slightly above normal. He just took a deeper breath than you. That's the variance between people. What if I tell you took it a minus 60? Hell, that ain't normal now. You're talking about minus 60 is what you need to do what I do at minus 25. Does that mean, Mitchell? Am I having a harder or easier time breathing in? Harder. That means I'm struggling to breathe in. Restrictive obstructive lung disease, sir. Restrictive. Okay, see that? Sneaky way. I'm telling you, restrictive from obstructive is just make the inspiratory effort give you this incredible negative pressure. You got to know, no normal person needs a minus 60. That means you're struggling. You're putting 2.5 times the effort into a normal breath. You're struggling to breathe in. That's a stiff lung. That's called restrictive lung disease. Okay? Restrictive lung disease is the one who's stiff. Any questions on that? You understand that, Josh? Go ahead. Okay. If you just rest at FRC, your heart is still beating. Yeah, your heart would have to work harder because you're staying at FRC. Whereas if you were going in and out with air, that means you're creating the pump that allows blood to come in easier. Because when you inhale, you suck in blood from your legs and then head and neck. See that? The heart didn't have to work that hard. It just receives it. Okay, when you exhale, you then push it forward to the left side. The heart didn't have to work so hard to pump it. Yeah, breathing in and out, folks, helps the heart do its job. The minute you stop breathing in and out, your heart has to do all the work now. Okay, and it can't keep it up for that long either. Yes. If you're taking a deep breath and pressure equalizes, what are you asking me? Yeah, pressure is equal to minus 25, and if you just hold your breath there, same thing. That means the heart would have to pump against that now, just to get blood to keep moving around while you're holding your breath. I think about it, like a child holding their breath. It's called a breath holding spell. What do? After a while, collapse, they pass out. Exactly what I just told you. If you don't have this vacuum all the time, you cannot keep it up. Blood flow in and out of your heart will just start dropping off until it's not moving anymore. That's why the child passes out. And then it come back to and start breathing again. You cannot hold your breath and hurt yourself. Children use breath holding spells to fool mommy and daddy. I want a new truck. And we tell them, anytime a child says that, you say, go ahead, son, go ahead. I want to see you pass out. Do that again. Because there's no harm done. Let them pass out 10 times every hour. Who cares? But they do that, hold their breath real hard, then they pass out because they want to scare the hell out of mom and dad and get their way. And so we just tell mom, leave him alone. Let him pass out again if he wants to. All right? There's no harm done to him whatsoever. All right? Let him pass out. And don't ever give in to that threat or else you just created a monster. I'm serious. They'll start holding their breath every day to try to get their way because mom thinks they're going to die. Mothers are always worried about that stuff. Fathers don't give a damn. Kid, get a job. Maybe pass out. Pass out. You better go get a job. $8 an hour, something. Pass out at work. Okay. All right. So intrathoracic pressure should always be negative. Is my point. Everybody clear on that? If intrathoracic pressure is positive, you got problems. So here's intrathoracic pressure. This is how they graph it. Carries, if I answer your question. I know this is in thoracic because the pressure starts out negative. See that? Gets more negative with the breath, and then all of a sudden gets less negative, but it never crosses that line. It never gets positive. Your thoracic cavity should never have positive pressure in it. But let's say, you understand this so far, Karis? I got a new tracing for you, though, before I answer your question. So your patient did this, and then all of a sudden, did that. I want you to interpret that for me. Don't give me a diagnosis. Interpret, first of all. The pressure went from negative to positive in the middle of breathing in. Only one thing can collect that fast. pneumothorax, then would be your diagnosis. Male or female? So male or female, first of all? Male. So male with what disease then? Klinefelters or Marfan. But you could have said female, and that would have been easier. All right. Estrogen or testosterone? Yeah, your patient stuff. Yeah. Estrogen or testosterone? Which one are you going to be picking? Thank you. Now, this is what I mean by I don't know how the test is going to end the question, and you don't either. First thing you do is interpret. Don't start putting a diagnosis on it yet. Interpret first. That way, even if you don't know the diagnosis, with that interpretation, go to the list of answers. You'll see there's only one answer that can fulfill that. Okay, all you got to do is just say, oh, pressure accumulated real fast, right in the middle of breathing in. Only air can accumulate that fast. Even blood can't accumulate this fast. Okay. All right. Let's see. Victoria, you have a question? Oh, wait a minute. Sorry.
Yeah.
Sorry, you were first. Hang on. She was right. She was first. Go ahead. Karis. TLC didn't become a negative. Thoracic pressure at TLC became negative. So intrathoracic pressure was minus 60 when the normal person only sucks in a vacuum of minus 25. That means you needed 2.5 times the vacuum to do what somebody normally does at minus 25. That means you're struggling to inhale. That's how you know it's a restricted lung disease. Obstructive has no problem with inhalation. So why would they be struggling to breathe in? Unless you talk about the end when they're COPD, then fine, because they have the same physiology of restrictive. That's why they have to struggle to inhale. So that's why, again, only if you say years of it, that means COPD. If you just say obstructive lung disease, that's a trap. That's not the answer. No. Now, even exacerbation won't do that. Yeah. The key is if you got to struggle to breathe in, that's restrictive property or end stage obstructive. Okay. All right. Now, Victoria, your question.
Yeah, so this goes back a little bit, but when you said like if you were to choke someone and they pass out, it's more from the lack of oxygen or the blood to the lungs and not oxygen to the brain?
Yeah, it's both.
Okay.
It's more directly related to there's no blood going through the heart or the lungs. That's why it's
Okay.
not getting oxygen. That's why the person passes out.
Okay, right.
Yeah, it's the brain who actually feels it, and that's why it shuts down and you pass out. Yeah. And Latoya?
This is like the physio to like understand how the iron lungs works for polio.
That's exactly how the iron lungs work. The iron lungs would move the chest wall for you, and because they were having trouble breathing. So it would create the vacuum so the chest wall has to go up. And therefore, it does the same pumping action as you would have done if you could breathe on your own. Remember, in polio, they didn't know how to breathe on their own. They had such muscle weakness, they couldn't even breathe. So the iron lung just breathes for you. Okay. All right. Very good. Very good, Tori. Yes, Paul. No. Do you understand interpretation first? Pressure became positive right in the middle of breathing in. Yeah, because it just went from here to here. That's called a pneumothorax if they ask for diagnosis. Now they can ask you what's the underlying diagnosis. It could be women versus men. It could be estrogen versus testosterone. If they wanted to be a male with estrogen, that'd be Klinefelters and then Marfan's. But theirs is because the collagen doesn't hold. It just pops one day. Yeah. Oh yeah. Yeah. The key is you got to figure out why the person has a pneumothorax all of a sudden. And that's what I said. I don't know how the test results are going to end your question. All they do is just go with new diagnoses. But the interpretation is the same. That's what I say. Start with interpretation. Don't start guessing where you've seen this before and think that is the exact same thing as what you've seen before. That's where students make their errors. I know. Yeah, and somebody with COPD is this point. They have hyperinflated lungs, but the functional part of the lung, that means the part of the lung that's actually ventilating, it gets smaller and smaller. Why? Because the mucus keeps clogging it up more and more. And then bacteria keep digesting the alveoli more and more. Why do you think they finally died from bronchiectasis? Because the alveoli had got eaten by bacteria. And that's it. And they die because there's no more alveoli to use. But your statement is very correct. Very good. All right. So intrathoracic pressure should always remain negative. It should decrease with inspiration. If it gets positive, then it will resist any blood or air from entering the thorax. Hopefully I've convinced you of that. So I told you the books always say it's continuous. That's not true. That's not true. All right. If you do not breathe in, there will be no pressure gradient for blood to enter the thorax. That means no pressure gradient for air to enter your lungs either. Kussmaul sign, increased JV during inspiration. Pulse period oxygen, exaggerated drop in blood pressure, usually more than 10 when you breathe in. And notice the two things I gave you before. Tamponade, number 1, pneumothorax, number 2. Halima, pericardial tamponade. What's the most common cause of that? Trauma. Again, gunshot wounds, stab wound, broken rib, just punctures the heart. Where do you do a pericardiocentesis? Where do I put my needle? Are you saying something? I can't see if your lips are moving. There's a landmark I gave you. Josh wants to remind you. Up where? From the neck? Oh, okay. Okay. I'm just playing with you. Yeah, xiphoid process. You understand? It's easy to feel on anybody, Halima. That's why you want to know that landmark. You stab the needle, large gauge, so blood can come through it. Like 18 gauge needle. Right underneath the xiphoid, aim for your left shoulder. I told you it goes right into the pericardial sac. Which chambers are anterior in the heart? Melissa, right ones or left ones? The other way. The right chambers are anterior, left ones are in the back. Okay? That's why if you're going to puncture anything with that needle, it's right side, it's right ventricle. And how do I prove that my needle is in the pericardial sac versus in your ventricle? I taught you that one too. Halima, any idea? Jess, how do I do that? Draw what fluid? I know, but how do I know my needle is in the pericardium and not in the ventricle? I give you guys a way on them to know. Yeah, remember I said, as soon as they get the pulse comes back, you take the syringe off, squirt a little bit on the gauze. If it clots right away, you're in the pericardium. Because that's fibrinous fluid, fibrin. There's a lot of fibrin in there. It clots immediately as soon as you touch something. Whereas if you're in the ventricle, your blood and your ventricles don't clot. And that's why it just sprays on there like water. That's how you know you're in the ventricle. You're in too far. Pull it back some. Okay, and retry the technique. That way you know you're draining pericardial fluid, not the ventricle. I told you, all of a sudden you drain 6 liters. You said, my God, look at all that fluid that was in there. No, you're busy killing your patient. Okay, you're draining all his blood. All right, so pneumothorax. If you got a tension pneumothorax, where do I put my needle? Halima, where do I put my needle? All right, Melissa, where do I put my needle? No, acid, where do I put my needle? Second intercostal space, mid-clavicular line. Allows the tension to escape. What happened in my chest tube, Karina? There you go, very good. Fourth or fifth intercostal space, mid-axillary line. Remember, angle upward. All right, so again, all stuff we've discussed already. Pericardial tamponade, most common cause, trauma or cancer, like Halima said. On a chest x-ray, you're going to see a large cardiac shadow. That's because you got a fluid around the heart. The x-ray doesn't know the difference. It sees this big old blob sitting there, okay? On an echo, though, echo goes through water, so it goes through your blood. So then you see this compressed heart in the middle, and all this is water, actually blood, okay? So large on x-ray, tiny on echocardiogram. And now your EKG must reflect that. How do I reflect that on my EKG, Justin? That all your chambers are being squeezed, man. So you squeeze the whole EKG. They'll say diffuse low voltage in every lead. There it is, tamponade. Notice all it's doing is reflecting what you're doing. This way you don't just memorize it because a book said that's what you're going to see. You actually visualize. Oh, you're squeezing, my friend. You're squeezing all the chambers. So diffuse low voltage is the way they're going to put it. Every lead has low voltage. All right. Pericardiocentesis, we just talked about on the xiphoid infra left shoulder. If somebody had a stab wound or gunshot wound, we usually take them to surgery after we get their pulses to come back and put in what we call a pericardial window. That means cut a hole in the pericardium. That way, if any blood goes in, it drips down to the pelvis. That way it can't kill you. Otherwise, you're going to go back to surgery in a couple of hours when that blood collects again. So pericardial tamponade, after a stab wound or gunshot wound, you got to know they're going to be bleeding for a while. You don't want them to get another one and have to go back to surgery. So we go up to surgery, and while we're there, we put a window in that pericardium. That way blood is drained down into the pelvic cavity. Karis. Won't that just cause inflammation as in pericarditis? Will it cause inflammation of whatever it touches in the pelvic cavity? Sure will. When is it okay to do something that might be harmful? Remind me again. Remind me again. Remind me again. Remind me again. So remind me of the answer. Thank you very much. That means we don't care how much scarring you get. You would have died if I didn't do the procedure. If I remember this, in case they ask you this on the test now, don't start thinking of some new question. I mean, she can see that, yes, it's going to be harmful, but hey, if I don't do something right now, you're going to die right now. I have to do it. Cut a piece of pericardium right out. Well, that's because the blood goes down your pelvis. Yes, it can cause scarring on your intestines, your uterus, your bladder, your vagina if you're female, rectum. Hey, but we can always deal with that later on if it happens. Right now, I got to save your life. Saving your life is more important. And that's why we have to do it. Okay? All right. So pericardial tamponade. Pneumothorax, traumatic, again, is most common, but spontaneous pneumothorax, especially with estrogen or collagen diseases. I gave you these numbers, less than 25% occupation with no symptoms, do nothing. More than 25% occupation or symptoms at any level, put in a chest tube. There's anatomy of the lung again. Just remind you, please look this over from time to time. That's why I put it in several different places for you. Now the vasculature. So we've done the airway part. That's chest wall and pleural cavity. You understand? Now I'm going to bring in the vasculature so we see how he will be affected by what we just did. Okay, here's the vasculature. Oh, you know what? This is why I put this picture right here. So you got capillaries, that's the vasculature, but the alveolar wall is out here. Okay, here's the airway here. Here's the alveolar space out here. Okay, so that means when you create a vacuum in this space, the alveolar space, all right, then that means everything moves that way, opens up. So that as you open up your airway, that means as you close off the alveolar space, as long as moving into that space like that, it's pulling on the lung to open up. Okay, so imagine, therefore, you're pulling on one side. So here's a vasculature, that's a blood vessel. As you are opening up the lung, traction fibers are pulling on it like this. Is that vessel going to dilate or constrict, Maria? Dilate. What happens to resistance? Go up or down? Down. Pressure goes up or down? Down. Flow goes up or down? Up. That means resistance. Did it drop or go up? Resistance drop. So that means when you drop intrathoracic pressure, you're also going to translate it to the vasculature. You're going to drop their pressure too. So whatever happens in the pleural space will make it happen in the vasculature. If you raise one pressure, you raise the other. Drop one pressure, drop the other one. They go in the same direction at all times. You should never try to separate them because you're not going to get a point. Okay? So now, as you dilate like this, Maria, blood flow increases. That's what you told me, right? That blood flow would then bring in oxygen. And we already said oxygen is the most potent pulmonary vasodilator there is. So if they ask you what's the most important pulmonary vasodilator, you say oxygen. But if they say what starts the vasodilatation, it's traction fibers. It's not oxygen. So traction fibers do the first 10%. Oxygen then does the remaining 90%. So whatever happens to your pleural space, immediately translate it to vasculature. Let's look at that. We give it the letter Q. The letter Q, Gustavo, Q, flow. As you breathe in, the lung inflates, pulling on traction fibers attached to the vessels. So as the vessels dilate, flow increases. As flow increases, oxygen dilates the vessels even more significantly, and that's what increases your Q. The increased Q keeps the pulmonary valves actually open longer, so that now S2 splitting occurs. That means if you want to accentuate any sound coming from the right side of your heart, what should I do? Jess. Have them breathe in, because there's always more blood flow on the right side of the heart when you breathe in. Everybody clear about that? Anybody not clear about that? I know. In ARDS and RDS. Okay, what's your question? Yeah, the traction fiber still works. Doesn't work that much, but it still works. The key is, even with the traction fibers working, it doesn't dilate the vessels enough to get enough blood flow to oxygenate the patient. That's why you have to apply pressure and get more oxygen in there. That's correct. Yeah, you have to oxygenate like crazy if you don't give them surfactant. That's why we give them all surfactant now. All right, so flow. Flow is therefore greater to the bottom of your lungs for 3 reasons. One more time, Angie. Flow is greater to the bottom of your lungs for 3 reasons. Number 1 is gravity. Your heart is in the middle of your lungs. So when the heart pumps, gravity pulls it to the lower lobe. You have to pull up against gravity to the upper lobes. It's easy to go with the gravity. So the number 1 reason why flow is greater to the bottom of the lungs is because gravity pulls it straight down. Number 2, there's less resistance in the bottom of your lungs. Why? Because alveoli are usually mostly collapsed, so that means they're not compressing the arteries. That's why when you inhale, it takes a while for the air to come down here to the alveoli, and so there's no pressure on those arteries. That's why plenty of blood flow. Third, there's more oxygen going to the bottom of your lungs as far as oxygen extraction. Remember I said when you inhale, you got a stack of a column of oxygen at the top, but you push an equivalent amount down here at the bottom. That's the one you're extracting the most. Any questions on that? These are the 3 reasons why there's greater flow to the bottom of your lungs. Any questions on these 3 factors? Anybody not understanding one of these factors? You understand it, Angie? Let's see if you do that. Your normal respiratory rate, Angie, is 12 to 16 breaths per minute. Each breath, each phase takes about half a second. So you breathe in for half a second, breathe out for half a second. So it takes about 1 second for each breath. You understand, Angie? That means there's 60 seconds for every minute, right? So that means for 12 to 16 seconds of each minute, where is most of the oxygen being extracted from? Top or bottom of your lungs? The bottom of your lungs. But the top of your lungs is always open. Ooh, watch out for this trick question. Show you in a second. Q increases on inspiration and decreases on expiration. Everybody clear about that? That makes sense to everybody? All right, S2 splitting, again, we said it's going to widen when you inhale, narrow when you exhale. That's because you have extra blood flow when you inhale. And now we can isolate everything on the right by inhalation, everything on the left by exhalation. Here's the part that's confusing people. Oxygenation is directly related to diffusion and perfusion. That means if you ask me a question about diffusion, I look for an answer with oxygenation or perfusion. You ask me a question with perfusion, I look for an answer with oxygenation or diffusion. I told you I like to get in and out in 2-3 seconds. That's because I know they're linear. The test writer can't give me these long stories. I need an answer with one of these words in it if I want to get a point. The others, I could kill us what they say. They're not the best answer now, are they? No, just look at these 3 words. Oxygenation is dependent on diffusion and perfusion. They're linear. So if you do something to one, all 3 will change in the same direction. That means if I ask you, how do you increase oxygenation? I say increase diffusion or increase perfusion. I don't have to look it up because that's the 2 main factors that govern his movement. Diffusion across the alveolar membrane and blood's got to pick it up. See? So if there's a question about diffusion, I know it's going to affect oxidation and perfusion. If there's a question about perfusion, I know it's going to affect oxidation and diffusion. The 3 words go in the same direction at all times. Yes. I said when you breathe in. So her question is, why does oxygen go to the bottom of the lungs, right? The oxygen is going to the bottom of the lungs. It's not the oxygen you just took in. Remember I explained earlier, when you take in air, you're putting a stack of oxygen here at the top of the lungs. But old air goes in down here at the bottom. You're just putting the same amount into the air, alveoli down at the bottom. But it's not the same air you just took in. Yeah, remember I told you, when you take a fresh breath, you got to stack in the dead space, filling up like this. That same breath will last, for a while before it's fully gone. Then you got to sigh or yawn again and fill it up. Anam? Anytime you have a ventilation problem, the top of the lungs will be affected more than the lower lobes. That is exactly correct. Vice versa. That means the bottom will be affected more than the top of the lungs. A PE that's located where? Right. Well, yeah. When the lower lobes will hurt you more than ones at the top of the lungs. Folks, they find out that 9 out of 10 PEs have no symptoms. Why? That means a lot of them happen at the top where you got plenty of ventilation. You're not even worried about it. And most oxygenation is being done at the bottom. It's not even affecting most of the oxygenation. See? Only 10% of PEs are symptomatic, folks. And they do autopsy studies. They see people with clots in their lungs that never had any symptoms from it, which means people throw clots all the time. But at least now you're understanding, when does it actually make a difference? The ones who are symptomatic, now you know. So one more time, folks, oxygenation is linear with diffusion and perfusion. They never go opposite each other. Whatever you do to one, you just affected all three. But watch this. This is a trick question that catches a lot of students. There's more oxygenation accomplished at the bottom of the lungs only with inspiration, which is what Anam is just saying. Is everybody understand that? But the top of the lungs is always oxygenating. Everybody see that? So that means the top of the lungs is the one that does most of your oxygenation. So here's the question they asked me. I think I missed it twice before I finally figured out what I was missing. They said, where is most oxygenation in the lung accomplished? And I'm telling you, I picked the bottom of the lungs. Why? Because every book I looked at said bottom of the lungs. This is where books will mislead you. The books assume that you understood they were talking about only when you're breathing in. But they don't explain that. You're supposed to figure that out. Well, most students don't figure that out. That's why they keep asking the same question on the boards and complex, because they know that most students don't figure it out. Okay? The bottom of your lungs is oxygenating the most only with each breath. That means if you ask me overall, the answer is the top. You have to say with each breath or with each effort. Then I say the bottom. See, that means you got to know the difference by the way the question is asked. The book was only talking about what happens with each breath. Because I remember looking, I'm holding the book up like this. I said, how come I didn't get it right? I said, the book said bottom of the lungs. And took me a while after I read the explanation a few times. Oh, now I got it. And then I finally started getting it right. They know how students misunderstand what's written in the books. And they know how to set it up so you swear you got it right, but you didn't get it right. Yes. The top of your lungs is always open. That's why you have upper part of your chest is always inflated. It never collapses. Open to the air. That means if they're open, oxygen can come in, carbon dioxide can leave. The bottom of your lungs collapses after you exhale. So it's not always open. Yeah. Karina.
Since you have used effort, this change the physiology of like swimmers who are horizontal? Vertical?
So swimmers who are horizontal versus being vertical, yeah, it just spreads out the pressure a little more equal. It still oxygenates more from the top of the lung, but they're able to equalize the perfusion throughout the lungs while they're swimming like this. Yeah, and that's why they can swim great distances or stay underwater a lot longer. Okay. So in other words, folks, let me say it one more time. If you don't understand it, say something now. Oxygenation is linear with diffusion and perfusion. That means if they ask you what affects oxygenation the most, folks, it better have diffusion or perfusion in that sentence. Otherwise, I don't care what it says, it's not the best answer. You can talk yourself into it, but you won't get a point. Okay? Be careful. Your language has to match the language of the test writer. This is what he expected you should have learned. Okay? And watch out for this question. Most oxygenations accomplish what part of the lung, Gloria? The top, because the top is always oxygenated, because it's always open. But with each breath, most oxygenation is where, Josh? Yeah, now you say bottom. See, now they're two easy questions, because now you clearly know the difference. But when you don't know the difference, because you're going by what the book said, like I did, that's where I got them right, and I got them wrong. I'm looking at the book, looking at the questions, how did I get this wrong? The book is saying exactly what I picked. And it said I got it wrong. I had to read the explanation several times to finally understand, oh, now I got it. Then I understood. The book, the way they said it, they just didn't say it. It was only talking about when you're breathing. Ventilation. Ventilation inversely related to PCO2. Because when you ventilate more, Melissa, you have less PCO2 left over. If you ventilate less, you have more PCO2 left over. You understand that, Melissa? So ventilation and PCO2 are inversely related. Does everybody understand that? So when you ventilate more, less left. Ventilate less, more left. So you got to know that relationship. Whereas oxygenation, diffusion, and perfusion are linear. There's no inverse relationship whatsoever. Look at the definition of ventilation, Lillian. An open airway, an open alveolar space. That means the respiratory bronchial, alveolar duct, and alveolus. The only three places I told you can exchange oxygen. But at the same time, that's the only place where carbon dioxide can come across to leave through the airway. True ventilation. There's ventilation, that means your alveoli are opening. Then there's ventilation that says your airway is open long enough to let carbon dioxide get out. Notice they just say hyperventilation all the time. But which ventilation are you talking about? Okay. All right. The measurement of ventilation is by the PCO2. If PCO2 went down, then you hyperventilated. If PCO2 did not change, you're just hyperpnic or dyspnic, but you're not ventilating. You're not hyperventilating. There's a difference. That's what I said earlier. There's a difference between your breathing and your ventilating. And please make sure you know the difference, because your attendant is definitely going to ask you. If you said a person is hyperventilating, then show me the PCO2 that went down. In obstructive, the PCO2 is always above normal, late in the disease. That's why they always say peripheral hypoventilation. Doesn't matter how fast they're breathing. They're breathing fast, but they're not hyperventilating. Be careful. It's so easy to pick that answer and not realize they're talking about obstructive lung disease. The PCO2 is above 40 all the time. No, you cannot call it hyperventilation. It's still called peripheral hypoventilation because they're not blowing off all their CO2. Now look at this trick here on them. There's more V to the bottom of the lungs, only on inspiration, but there's more V at the top overall. Same thing you said earlier, because the top is always open, so it's always ventilating. The bottom is open only when you inhale, so it's only ventilating when you inhale. Yes, sir. This is why COPDs are chronic retainers of CO2. They're breathing faster and faster, but they're not ventilating the CO2 off. Yep. All right, so now we create an equation. Pulmonary airway. All right, I mean FRC. This is at baseline. Airway pressure equals atmospheric pressure. Is that minus 3 to 5 equals positive 3 to 5? Okay. When you inhale, look at this. Airway pressure falls down because you're creating a vacuum down here. And that's why atmospheric pressure, the air moves into your lung. At the end of a deep breath, look at that. They equalize again, but at a new set point. So you got a vacuum of minus 25, the air will fill up with a positive 25. And then when you exhale, it's just the opposite. Airway pressure then rises to overcome atmosphere, and that's why it comes out. So in other words, the airway pressure is the only pressure that gets positive with each breath. Very important to know, folks, because remember, vasculature and pleural space pressure stay negative with each breath. They never get positive. Getting positive will kill you. But your airway pressure is allowed to get positive because you give me a net vacuum minus 25, I give you a bubble of positive 25. You give me a minus 30, I give you a 30. That's how you get more air to come into your lungs. Take a deeper breath. So pulmonary airway pressure is the only pressure that gets positive with each breath. Everybody clear about that? The other two stay negative with each breath. So breathing cycle, normal, tidal volume. See, changing air. So as you start breathing in, see that pressure goes up and that pressure goes down when you exhale. Okay. Alveolar pressure follows a sine wave. It goes down when you breathe in, goes up when you breathe out. So it looks like an S lying on the side. Now, test writers know how to mix things up a little bit. What if I put A here, B here, C here, D here, E here at the end? Jess, do you understand what I just put up here? First half is when you breathe in because the pressure is getting negative. That's how you remind yourself of that. Second half, pressure getting positive. That's when you're breathing out. Okay. Which letter represents FRC? Force reserve capacity. No, FRC is not the max of anything. You're using the wrong word. That's our starting point. FRC is a starting point. Thank you very much. See, when you say the right word, now you see the answer real easily. Okay? FRC is an A or E, because remember we started FRC, come right back to FRC. That's what I'm saying. Be able to talk the language, folks. That's what I'm saying. And use the right words when you're responding to me. Because I want to make sure you can find the answer real quickly. Because if you don't use the right words, that's why you're having a hard time figuring out which answer to pick. Say the right words, you'll see there's only one answer with that word in it. Now it's an easy question. Where is tidal volume at, Karina? Huh? In the middle of breathing in, that's your tidal volume? Thank you. It's at the end of breathing in. That's tidal volume or total lung capacity, depending on how big your breath was. Anna. How would it change your altitude? Everything will still be the same. You just won't be able to bring in enough oxygen because there's not enough oxygen in the air of high altitude. But the cycle doesn't change. Well, atmospheric pressure will change. So you're talking about, if you want to talk about, let's see, so interpleural pressure will change because the pressure out here in the environment will be pushing back on your lung. So that means that's why you can't take such a deep breath. And even you do, you still don't bring enough oxygen. You're still short of breath. That's why you hyperventilate at high altitude, correct? All right, so that's breathing cycle. Then they have breathing cycle this way, okay? So, and exhalation and inhalation is the same thing, but then they modify it by doing all kinds of other things, taking shallow breaths, deeper breaths, and so forth, okay? Pulmonary function studies. So I put in a bunch of these. I want to show you guys because they love these drawings on the test. You got to be able to look at it and understand it. Look at normal. Remember, it always starts, you got to understand what normal is. And they usually draw the normal for you. Okay, look at this one. Normal, you breathe in, notice getting negative. When you breathe out, it got positive to a peak and then drops. Okay, but look at asthma, an asthma attack. See that? You take a shallower breath because you got what? Bronchospasm. And then look at that. You can't seem to exhale as much as the normal person anymore. Okay, because again, your airway is now full of mucus and spasm. So they give you all kinds of different ones. Look at this one, emphysema. Now we're going to talk about it in a second, but emphysema is the only one who has restrictive and obstructive properties. So it's restrictive because you see that this is shallow compared to normal. But look at breathing out. Look how much the person has to struggle to climb up that hill and then drop. So that means he has problems with breathing in and problems with breathing out. That means he has restrictive and obstructive. Emphysema is the only disease that has both components in the same person. So the question then becomes, how do I answer the question when I get to the exam? It has both properties. First of all, does everybody see both properties? Everybody see it now? Say something if you don't see it. That means they took a shallower breath in, that's restrictive. But they struggle to get it out, that's obstructive. That's both components. So now, let's say they ask you about the blood gas. You got to put the two together. You say, well, the obstructive component says the PCO2 will be high, pH will be low. The restrictive component says PO2 will be low. Put that together, that says blood gas. That's the blood gas for emphysema only. What if they ask me, what are you going to see in the airway? Folks, the way I treat emphysema, it has both components, but when you're answering question about them, answer it as an obstructive lung disease. They have airway mucus, airway narrowing, thickening of the airway, increased breathing index, the diaphragm bronchiectasis. Everybody follow? Okay, I just treat it as a obstructive lung disease when they ask me about questions about it. But because it has a restrictive component, if they ask me about diffusion, I also have to say decreased. Other obstructive lung disease don't have decreased diffusion, but he does. How do we monitor or measure diffusion? It's called DLCO because it's measured with carbon dioxide, DLCO, diffusion capacity of carbon dioxide. So all restrictive have decreased DLCO. Emphysema is the only obstructive with decreased DLCO. Otherwise, obstructive lung disease doesn't have a diffusion problem till the very end when they start to take on restrictive features. Here's another one I saw that fooled me at first. This is for fixed upper airway obstruction. Like if you got vocal cord paralysis. So the person, notice, is almost block-like breathing because when they try to breathe, their vocal cord is kind of messed up. So it doesn't open quite as much, nice and flat. See that? That's what they mean by fixed upper airway obstruction. And then breathing out, same thing, fixed upper airway obstruction. That's like a paralyzed vocal cord. Or you got a child with a foreign body stuck in his trachea. Same thing. See? All right, but anyway, this is just different samples. Oh, look at fibrosis. See that? A real shallow breath compared to, look at this. This person took 6 all the way down to 1. This guy took 3 to 1. See, that's a fibrotic lung. That means it's being squeezed down. And then he struggles to breathe out. But that's somebody who's got fibrosis. Very little span of breathing in because he's got fibrotic lungs. He can't breathe in for that long. All right, but anyway, just put a bunch of examples for you to look at. How does the brain monitor? Okay, pulmonary physiology. Here it is, signals from the lungs and chest wall. Signals coming in from the lungs and chest wall. J receptors are found in the interstitial of your lungs. This is for anybody with interstitial lung disease. Ashley, who has interstitial lung disease? Restrictive or obstructive? Restrictive. All the restrictives have their J receptors firing like crazy. This senses interstitial particles and makes you breathe in more. That's why restrictive, they're tachypnic, but they're spending more time breathing in because these guys make you breathe in more. Prolonged inspiratory phase, like I demonstrated for you. Versus slow adaptive receptors, Sandy, they're found in the ribs, especially the sternocostal junctions. They monitor how much your lungs inflate. And they're stretching. It says, hey, exhale, would you? See, because you're pulling a rubber band. I say, hey, you're pulling too much. Exhale. They sense stretch and inflation. They cause exhalation. So who's getting the signal to exhale more, Anders? Restrictive or obstructive? Who's getting the signal to exhale? Exhale. The inhale is J receptors. To exhale more, that's obstructive. That's why they have to prolong expiratory phase. Pursed lips. All that stuff they're always describing. Sandeep? The pulmonary function test we're looking at before, yes? That graph had everything on it. What do you mean, read the other way? Okay, let me see how far back I gotta go. I can't remember. Wait a minute. Which one? This one here? Go here?
This one, yeah.
Okay,
Like, if we look at the first, like normal, right?
okay.
Where 1 is, right? Because you were tracing it from left to right, but isn't breathing process gonna be right to left? And then that 1 would be your residual volume, and then the 6 on the left side would be your.
Oh, okay, you're right. Yeah, I think I made my arrow go this way, but it's actually this way. You're right. I didn't, because you start out from a lower number and then go to a higher number. So that makes sense. Yeah, so I think I did move my arrow the wrong way. Yeah, so you're right. Very good. All right, but any other questions? I just want to make sure I didn't fool anybody else. I made my arrow go this way, but I didn't look at numbers carefully. They're going this way. So that means you got to go this way and then this way. So notice the most effort is at the beginning of breathing out. See that? Yeah. So same thing most effort that is when you're starting to breathe in. Okay, so it's always there, and then you expend a lot of effort. Remember, you can blow out 80% of everything in just 1 second. That's what they're talking about right here. 1 second. You got most of it already blown out. Then the other 4 seconds is to blow the rest of it out. All right, good point. All right, monitoring J receptors, monitor anything or sense anything that's the interstitium. That would be all the restricted lung diseases. They all have interstitial particles. All the pneumoconioses, interstitial particles. Whereas when you got hyperinflation from obstructive, then the slow adaptive receptors are the ones who are firing. And that's why now you spend more time breathing out. The same way restrictors spend a lot more time breathing in. Any questions on those two? I noticed they're talking about here the pons and the medulla. The medulla does basic breathing pattern, then the pons responds to your environment. Breathe more, breathe less, and that's how it modifies it. Like when you're scared, you breathe more. When you're sympathetic, you breathe more. But when you're tired, you breathe less. So that's the pons responding to the environment. And here comes the sinuses. Yes, we're all airheads. Don't deny it. All right, so sinuses. You have 4 sets of 2, total of 8. When I was born with me. Meaning what? Maxillaris ethmoids are there at birth. That's how I remember that. I was born with me. Maxillaris ethmoids are there at birth. They love to ask that question. Which sinuses are present at birth? Only 2. Sphenoidals come in after age 2. Frontals come in last after age 4. What's going on with these pockets in your head? Well, let's see. Montessori. You got cilia in your sinuses. Remember, sinuses are continuous with your respiratory tract. If your head moves to one direction, the hair cells bend to the opposite direction. Everybody understand? That's what your brain actually monitors. So the opposite direction, as the bending tells me that's the side your head just moved. So if your hair cells bend to the left, the head just moved to the right. If the hair bends to the right, then your head just moved to the left. Sinusitis is what we care about. If you have inflammation of your sinuses, what problems are you going to run into? All right. That means the sinuses fill up with fluid. All of a sudden, hair cells go nuts every time you move your head. Because let's say I move my head to the right because I got allergies, as you already know. If my head moves to the right, the hair cells move to the left. If there's fluid in there, they're moving the fluid and beating it this way. Everybody follow? But that fluid will hit the wall of my sinuses on that side and come right back here. And my head didn't move. But my brain doesn't know the difference because he sees the hair cells move again. So sinusitis, when I start feeling like I'm moving around the environment, that's called dizziness. That's why sinusitis causes dizziness. When I feel like the room is spinning around me, same movement, that's called vertigo. That's why sinusitis also causes vertigo. And that's why before I started these allergy shots I get, my goodness, I would have so much vertigo I could barely move. Because the room was spinning. I'm trying to hold myself from falling. You feel like you're about to fall to the ground. The brain says, hey, the room is moving. And so it's just so weird. Every time I walked, I was like, oh, I got to hold on to the wall. I thought, okay, I need a cane or something. It's like, I don't even know what I'm doing. So you're surfing in there, right? Because your brain keeps saying you're moving. And I'm saying, no, I'm not moving. The brain says, hey, the room is spinning. I said, no, it's not spinning. But I don't know that. I'm just feeling like the room is moving. So all of a sudden, before I'm losing all my balance. Okay? So sinusitis can cause dizziness when you think you're spinning, vertigo when you feel the room is spinning. Everybody understand the difference? When somebody says, I felt dizzy, you always got to ask them, did you feel like you were moving or the room was moving? Because everybody calls everything dizziness. But you got to know the difference as a doctor. Sinusitis, folks, the most common cause of sinusitis is a viral infection. No, sorry. Before that, allergies. Doesn't even need a virus. Allergies, number one. That's what causes mine. And you got millions and millions of people with allergies. So that's why it's number one. Then viruses are number 2, which means the majority of sinus infections, you don't have to treat it. Just symptomatic treatment. A little antihistamine to unplug your nose. They got these rinses now. You guys have seen it, the water rinse, the potty, the what do they call them? Neti pot, yeah. To rinse your nostrils. You blast the water into one side, comes out the other side. Just rinse the bugs out of there. That's been shown to make people feel better and decrease their symptoms. Makes sense. Everybody understand? Okay. Then when you have bacterial sinusitis, okay, how do we know you have bacterial sinusitis? 2 clues. Number 1, symptoms beyond 7 days. They say if somebody still has symptoms after 7 to 10 days, you probably need to treat them. That's usually bacterial at that point. And the bacteria, the same thing as all the respiratory tract. Strep pneumonia, H. influenza, Neisseria catarrhalis. And what's the drug of choice for it? Acid. Antibiotic for respiratory infections is what? Is amoxicillin. So no different here. If they're not better within 7 days, add clavulanic acid, repeat. Okay? But sinusitis, treat symptomatic, it's just a virus most of the time. So the second clue that you have a bacterial sinusitis is called second sickening. It means the person just had a little runny nose, nasal congestion, sinusitis. You can feel the pressure in the sinuses. And everything was going well, and let's say 4 days later, 5 days later, ooh, the pain becomes real excruciating. A bacteria just took over. Because viruses make it easier for bacteria to invade. That's why they call it second sickening. Because you already knew how, the mild illness you had, and I was, ooh, and then it got worse. That's an infection that just started up. Treat it with antibiotics. I know. The sinusitis, the reason for the headache is increase in the cranial pressure. That's correct, because there's fluid in there that should not be in there. Yeah. And then swelling. Sinusitis. Oh, yeah. The most common sinusitis is maxillary sinusitis. Why? It's the only one that drains upward against gravity and then into your nostrils. Everybody else is draining straight down with gravity. So that's why with maxillary sinus, it's hard to clean it all up. Because you got to wait till the cilia pull all that mucus up and then down into your nostrils. Okay? That's why you see some people hanging upside down to drain their sinuses. All right, any questions on sinusitis? So in sinusitis, we don't run any tests. We don't do x-rays, we don't do CT scans, don't fall for that. Symptomatic. So how do I know you got frontal? Pain right above your eye. Sphenoidal, pain right behind your eyes. Ethmoid, pain right here at the bridge of your nose. And maxillary, pain in your cheeks. And it hurts when you bite down on food. So history is what we go by. All right, so that's sinusitis. Then we got aortic and carotid bodies. If you guys remember, we did aortic and carotid sinus. That was for baroreceptor. That's for volume. This is the body. These are called chemoreceptors. They measure chemicals. So aortic body is found in the arch of aorta, right in the middle. Measures CO2, pH, and hydrogen ions. Notice, Sandeep, nobody measured PO2. That means blood going around the aorta to your body. Nobody measures the PO2. You see that, Rachel? That's why the periphery of your body, folks, is most affected by hypoxia. Nobody measured it. So it's real sensitive. So you got PO2 sensors in all arterioles. And when they measure that just PO2 is low, what do you want to happen, Halima? Do you want the arterioles to dilate or constrict? What? I said, what do you want the arterioles to do? The arterioles have PO2 sensors. So when the PO2 is low, they'll sense it. Because remember, aortic body never measured it. So that's why they're sensitive to it. All right, so when they measure the CO2 is low, what do you want the arterioles to do? Constrict or dilate? Why do you want them to dilate? Make sense of it for me. Let's see if Melissa can help you. What's that? No, she's saying that hypoxia should make the arterioles dilate. Why should they dilate? Okay, what are you saying? You took back over? What are you doing? To increase blood flow and get me some oxygen. Everybody understand? I want you guys just use simple thinking to remember the information. Because if you're hypoxic, that means, oh, hey, we need some more oxygen here. Then dilate, bring more blood with oxygen down here. That's how to remember how it works. Look at the carotid body. Saba. Carotid body, look at the bifurcation of your internal carotids right above your carotid sinus. What does the carotid sinus respond to? I can't remember. Saba says stretch, right? Volume. Okay, look at this. Carotid body measures PO2, PCO2, pH, and hydrogen ions. Now, it makes sense that the carotid body should measure everything. Why? Because your brain's the most important organ, and you better measure everything going up there. So your brain is therefore more sensitive to hypercarbia. That means high CO2. Peripheral tissue, more sensitive to hypoxia. Your brain is more sensitive to hypercarbia. Any questions on that? Okay. So the brain is more sensitive to elevated PCO2, Bailey. More sensitive to PCO2, because remember, the brain responds to the CO2 before it responds to hypoxia. But if you got hypoxia and hypercarbia at the same time, then it's a synergistic effect. You follow? That's because if your PCO2 is elevated, are you having trouble with diffusion or ventilation? Yeah. You have a problem with ventilation. The brain says, hey, man, you're not ventilating. Then the PO2 goes down, and the brain will say you're having trouble with what? Yeah, diffusion or perfusion. In other words, hypercarbia tells the brain, hey, you're not breathing out. Hypoxia tells the brain, hey, you're not breathing in either. So what's the brain say? Oh, man, you just died. Wake up! That's why you wake up suddenly in OSA, because that's the two signals. Because when you're overweight, a lot of adipose around your neck, what happens when you hit REM? The fat tissue just collapses your airway. You cannot breathe in or out. And that's why all of a sudden the PO2 drops like this, PCO2 rises like this. The two signals give you this sudden jolt that says, what, man, you just died. And it's like, and goes right back to snoring. Okay? And that's why when they wake up in the morning, they don't feel refreshed. They never spend that much time in REM. Every time they fall down the REM, airway closes off again, we're right back where we started. And now at least you know what we look for in a sleep study, because they'll ask you what's the sleep study going to show. They always say hypopnic, that means breathing stops. Hyperpnic, because you wake up, start breathing real fast. That's what we measure. And also they got PO2 and PCO2 monitors too. You can measure that as extra information. Okay. Now, forms of CO2 for your brain, Steve. 90% of CO2 in your brain is a form of bicarb, or 90% of CO2 in the blood. Let me say it that way. The brain doesn't take all this bicarb. 90% of the CO2 in your blood is a form of bicarb. Now, that's a trick question. Why? They'll ask you how much, where do you find most of your CO2? CO2 is an acid. Doesn't make sense that most of it's in the face of a base, unless you understood what I just explained. Okay? 90% of your CO2 is a form of bicarb. I'll show you why in a second. 7% is attached to hemoglobin on a carboxy terminal and the amino terminal. Only 3% is dissolved in the blood. Only 3%, Ina. The 3% that's dissolved in the blood is the only one that can get into your brain. This is the one that affects your breathing. And this is one that the brain is more sensitive to. Carbon dioxide dissolved in your blood. So that means who has a higher dissolved CO2 content, either restrictive or obstructive? Obstructive, because they have a higher PCO2. Does that make sense to you, Karen? Make sense to you, Melissa? 0.03 times whatever higher number is higher than a lower number. Everybody understand? Restrictive have a low CO2 because they're hyperventilating. So because the brain of somebody with COPD sees more dissolved carbon dioxide every day, eventually, now this is years down the line, they'll just desensitize the CO2 receptor and said, doggone, I keep asking him to exhale and he just won't. He doesn't know that you can't. You're exhaling, but no carbon dioxide is leaving. So after years of having high CO2, your brain will become desensitized to CO2. That means the brain will force you, the obstructive lung disease patient, now we call you COPD, will force you to let your PO2 drop because that's the only other signal left. Everybody understand that? All of a sudden, as you enter end-stage COPD, their PO2 actually drops. They're doing that on purpose because that's the only other signal the brain responds to. Is either you respond to PCO2 or respond to low PO2. Well, the CO2 receptors got desensitized. It's not responding anymore. Only thing I can respond to from your brain is hypoxia. So I'm going to force you to let your PO2 drop. Normal PO2 is what number, Sandra? Normal PO2, 60 to 100, it's around 80. So that's why they'll let the PO2 run between 55 and 60. Notice, just slightly low. But guess what? That's all it takes to keep you breathing. Otherwise, you would have stopped breathing because there's no more signal. You understand, Halima? You understand what I just said? You understand, Melissa? Okay, I'm not convinced. I'm gonna give you a question, see if you do. And let me say, you said you understood. You got to show me that you do. And here's your question. So here's somebody with COPD, and they're desensitized. They're keeping themselves PO2 55 to 60 to keep the respiratory drive. And here you come as the ER doctor, because they showed up in the ER, and you slap a whole bunch of oxygen in their face. You will shut off their breathing. This is that message. I always say you can kill somebody with oxygen, especially COPD. Because if you give them a whole bunch of oxygen, you'll desensitize their hypoxic receptors. And that's it, shut off breathing. They'll die right there in the ER for you. Or go into a coma like the one I saw. Just went straight into a coma. That's because it got shut off. Because the ER physician did not know. You can't just give them a whole bunch of oxygen. So what they do on the test, they give you somebody with COPD, meaning they'll tell you he's like 60s or 70s, and he's had it for the last 40, 50 years. You gotta know that's pretty chronic. And he comes into that ER, and they put a couple of liters of oxygen in his face. And all of a sudden he gets more delirious. That's because he's hypoxic. If you didn't know what I just explained to you, the answer about taking oxygen out of his face wouldn't make sense to you. Because you think he's delirious, he needs more oxygen. No, it's the opposite. You're turning off his breathing and he's fighting you. He's trying to tell you, get the oxygen out of my face. You're shutting off the only signal I got. So whenever you see COPD, and as soon as they give him oxygen and they get more delirious, that's somebody who's been desensitized. Take the oxygen out of your face, or else you're going to kill him. On him. That's CO2 narcosis. That's exactly what they call it. I told you, that's always a word game. They just give a new title, and all of a sudden physicians have no idea what it is anymore. That's because they never learned it here, where it's basic. Okay? So get the oxygen out of your face, folks. So how do I know? So you suspect they're desensitized. I got 3 clues. Number 1, they're barrel chested. What's all this in here? CO2. How come you hold on to it? Because you don't feel it. Think about it. Barrel chest, that's all carbon dioxide. That means you got a CO2 75, 85, 90. And it doesn't even bother you. But you and I, if your PCO2 hits 60, you pass out. And they're walking around CO2 at 90. I've seen a 100 and something. Didn't bother the guy at all. That's because he's been this way for decades. Okay? So that's the first clue. Second clue. You see a very high bicarb on his blood gas. It takes about 5 minutes to come back. If that bicarb is very high, that's buffering the high CO2 that he's had for years. Because you can't raise your bicarb to 40s acutely. That's impossible. Remember, the kidney takes 2 to 3 days to get anything done. Just so you don't talk yourself into, well, it's because he's compensating. You can't compensate the same day. He's had this for years. Okay? Or if you're lucky enough to see the CO2 in the real high numbers, meaning he's hyperpnic, so he's breathing 30, 40 times a minute, but his PCO2 is still 87. You say, oh, that means this guy's desensitized a long time ago. So 3 ways to detect that your COPD is desensitized, meaning don't give him a lot of oxygen or else you might just kill him with that oxygen. You would think every time oxygen helps people, except in COPD. You might actually kill them. Yes, sir. That's correct. So if you put in somebody with obstructive lung disease, well, COPD on a ventilator, you got to go with very low FiO2s. In the air here is 21%. You may start out with like 23, 24%, just low number. You see your blood gas come back and you see all the high bicarb, high PCO, you say, oh, forget it, turn off the oxygen. He doesn't even need it. Okay. In fact, he comes in hypoxic, we send him home hypoxic. I had to learn that from another attendant who was trained under Dr. Rick. He's the one that picked it up. His partners didn't pick it up. We had a guy on a ventilator, and every weekend when we tried to wean him off the ventilator, we said, oh man, look at his PO2 drop. We put like 2 liters on him. Psst, guy was right back in a coma. And we put him up in the ICU on the ventilator again. We ventilated him for a whole week. Come the next weekend, we try to get this guy out of here. And PO2 low. Give him a little taste of oxygen. Put 2 liters in his face, psst, back in a coma, back up to the ICU. We did this 3 times. Till the 3rd week, here comes the partner. And he said, how come this guy's here? What's going on? And we explained what's going on. He said, oh man, don't you guys understand pulmonary physiology? He came in hypoxia, he has to leave here hypoxia. As a resident, you're always saying, if it's low, bring it up, if it's down. If it's high, bring it down. we weren't trying to reason out why he keeps doing it. None of us knew that we were the one causing this guy to go in and out of ICU for 3 weeks. Because we're busy trying to correct his PO2. You got to let him go home hypoxic. All right, all you do is document that you know what you're doing. And that way, in case the hospital gets audited, they say, oh yeah, well, the guy got COPD. Okay, that's fine. Hypoxia is okay. Okay. All right. Now, what about this bicarb made from CO2? Let me show you how that happens. It's called a chloride shift in your red blood cells on the periphery. All right. What do you got? First, you got CO2 and water. If you guys remember that, we've done it in the sweat glands, we've done the salivary glands, same old stuff. Take CO2 and water coming in from the tissues. Carbonic anhydrase turns into carbonic acid, which then breaks up spontaneously the bicarbonate H+, right? And then to get this bicarb out of the red blood cell, look at that, you exchange it for chloride. This is a chloride shift. That means now the chloride is inside, the bicarb is out there in the blood. That's to help you buffer the acidosis. It serves a purpose. But that means your venous chloride is now higher or lower, Karis. Chloride is coming into the red blood cell. The venous blood is outside of this RBC. So the venous chloride is lower because it's all in the RBCs. When you get to the lungs, folks, what do? Reverse everything you see here. Okay, reverse the whole reaction, and you go back to CO2 and water and exhale CO2 and water. When you exhale, you got humidified carbon dioxide coming out of your mouth or your nose. That's because you just reverse everything you see here. So that's why arterial chloride is higher, because it just came from the lungs. They love to ask, explain that. Carbonic anhydrase, if they just want an enzyme, okay, it's called a chloride shift. They just want to give it a name. But this is how you bring bicarb out of a cell, but it went in as CO2. So it's for real. 90% of CO2 is swimming around the blood as bicarb. Respiratory centers, the medulla controls your basic respirations, and then the pons responds to the environment. As you see here in the pons, you got apneusic center and a pneumotactic center. Pneumotactic center is at the top of the pons, apneusic center is at the bottom of the pons. Pneumotactic center makes you breathe out, so it prevents pneumothorax. That's how I remember that. Apneusic center prevents apnea, so it makes you breathe in. Because apnea means lack of inspiratory effort with or without bradycardia for at least 20 seconds. So apneusic makes you breathe in more, pneumotactic makes you breathe out more. So you know which one is for restrictive, which one's for obstructive. Pons. Which cranial nerves are found in the pons, Ida? Nine, 10, 11, 12, you're down in the medulla now. Remember, 3 groups of 4, but 3 and 4 outside the brain. So 3 and 4 in the midbrain, 5 through 8 in the pons, 9 through 12 in the medulla. All right. Medulla responsible for your basic functions. It has a respiratory rate of 8 to 10. Jess, respiratory rate of 8 to 10. Is that faster or slower than when you're wide awake? Slower, because we have 12 to 16 when we're wide awake. So if we're breathing much slower when when the medulla is the only one working, i.e. when you're asleep, okay, is your PO2 can be higher or lower? Lower. Everybody following this argument? The PO2 is lower. What's your pulmonary vessels do when you're sleeping? Constrict or dilate? Oxygen is the pulmonary vasodilator. So hypoxia is the opposite. They're going to constrict. So if you constrict your pulmonary vessels when you're asleep, what happens to pulmonary pressure? Increase pulmonary blood flow. Decrease pulmonary capillary wedge pressure while you're asleep. I thought wedge pressure is total flow. That's what I'm saying. It's talk it out. Now don't just start stabbing it with guesses. So hypoxia when you're asleep says pulmonary resistance and pulmonary pressure both have to rise. And therefore pulmonary blood flow has to drop. So capillary wedge pressure has to drop. Everybody following that so far? Is that going to create a resistance or volume problem? The resistance is going to affect pulmonary or aortic valve. Pulmonic valve going to affect S1 or S2? S1? S1 is mitral tricuspid. As I said, talk it out. I know, but that's why I know when you guys are guessing, because now it doesn't even match anything I taught you. That means you let the brain just start to stab out with a guess again. No, take your time. That means if I ask it's gonna affect S1, S2. Actually, what was S1 again? Okay, what is S2 again? We're on pulmonary. S2 is pulmonary. That's how you know. There's no talking 7 to S1. All right, so it's gonna affect S2, which means it's gonna get louder or softer. I didn't say when you inhale. I just said it's gonna get louder or softer when you have high pulmonary resistance. You know, it's louder when you have high resistance. Okay. So that means, is the right ventricle gonna hypertrophy or dilate? Hypertrophy get thicker or thinner? Thicker, contract harder or softer? Harder, which makes S1 louder or softer? Louder, which means CVP will rise or fall? Rise. That's how it's done, girl. Take your time. Okay? So imagine, therefore, listen to me carefully. Imagine if you make this even more pronounced because you're overweight, because you're obese, and you got fat around the neck cutting off your airway while you're sleeping. That means you're going to develop pulmonary hypertension one night and your right ventricle cannot pump against it. That's why they die in their sleep. So what if it was a baby whose face keeps going into the blanket like that? Call it SIDS if you like. Sounds like the same thing to me. Why do athletes who are overweight and obese, how come they die in their sleep? There's been football players who die in their sleep. There it is right there. OSA is what's going to kill you. You're going to die in your sleep one night. Why? Because pulmonary resistance becomes so high, your right ventricle says, I can't pump against this. And then that's it. They die in their sleep. That's why they say, folks, when somebody starts snoring and it's creating a problem, they're tired the next day, you got to do a sleep study. Because if it's significant, you got to treat them. Because it's not something small. One day they will die at a young age, 40s, early 50s. That's it. Just dying in sleep and nobody. I said, oh, Mr. Johnson died. But it could have been prevented. Could have been prevented. That's why we give them oxygen and put on their nose at night. Okay? All right. Brain dead. What's brain dead? No function above your medulla. Criteria for brain dead. Number 1. Okay? I got to prove your cortex no longer responds to the environment. How do I do that? I check all your senses. Remember, all sensory information except olfactory must go to cortex. Okay? No, sorry. Even olfactory goes. It just only olfactory does not go to thalamus. I misspoke. All right. So all sensory information goes to the cortex. So we check all those senses, nothing. After you check sensors, then you check the what's it called? That basic, hang on. No. The cranial nerves, there's a term for it. Oh, damn, what am I drawing back on the term? No, the cranial nerves, collectively are called something. So we check the cortex. Oh, second thing, prove it with a flat EEG. We just pull up an EEG machine by the bedside, hook them all up, nothing. So 2 things must prove the cortex is gone. Oh, it just came to me and it disappeared. Brainstem, thank you. Then the next thing you do is check all the cranial nerves, brainstem. And of course, you have a different test for every cranial nerve, nothing, not responding at all. That means brainstem is gone too. Okay. Then you run an apnea test. Take them off the ventilator for about 5 minutes, 5 to 10 minutes, and nothing. No change in respiratory rate, no change in anything. That's how you know they're not sensing a thing. And then 2 doctors must agree, take them off the ventilator. They've gotten to a point where you don't have to fight with the family anymore, folks. Because in the old days, doctors would just say, hey, can we take your mommy off the ventilator? What do you mean take my mommy off the ventilator? No, you can't take my mommy off the ventilator. Families didn't like you ask them that question because the families thought they're then responsible for killing their own mother. Nobody wants that. They prefer if you just come and tell them, here's what we think we ought to do. You say, we're going to keep your mom comfortable. But right now, I've checked her. She meets the criteria for brain dead. Dr. Wilson here has checked her. He agrees she meets the criteria of brain dead. So we're going to keep her as comfortable as we can until she makes the transition. And we'll let you know when that happens. And the family said, thank you, doctor. That's it. Otherwise, if you ask for permission, you just created a court case. They'll say no. You don't have to take them to court to get mom off that ventilator. Because you can keep a person alive on ventilator for years, folks, but you're paying the bill now because they're not paying it. You're keeping a dead body alive. All right, so that's why they've created this criteria, so you don't have to get yourself into legal trouble and then the hospital stuck with this huge bill that nobody can pay. Okay, so brain dead, that's the criteria for brain dead. Next, comatose. What is comatose? A comatose says your cerebral cortex is still alive. That means when you test their senses, oh, they respond. How they respond? You may see that their heart will race, but you'll see a response. It just won't be with their voice. Think about, Melissa, you have a question? Yeah. Yeah. Yeah, so she works at a hospital where there's a unit that keep brain dead people or comatose patients alive for years. The key is you gotta know the difference between brain dead and comatose. Brain dead, if you present it properly to the family, you don't have to keep them alive for years. That's what it's gonna do if you present it the wrong way. They think, Mom, you're still alive. Yeah, if they respond to sensory information, that means they're still alive. That's comatose. They're not brain dead. Yeah. Think about why we tell families, talk to them. They can hear you. You just can't respond. We tell them, hey, put the TV on your favorite soap opera. They can hear it. People are comatose and they come out of it years later. They can tell you what happened on their favorite soap opera, which means they heard it every day when it was playing. Play their favorite music. They can hear it. They just can't respond to you. But we know their heart rate can change, which means they're responding. That's how you know they're comatose. All right? Cynthia, your question. Patients who are brain dead can still take breaths on their own. Where's that breath coming from? That's why, yeah, so you should have fired off your question before I fired mine off. So her question is, where's that breathing coming from? Let me ask Asit. You asked the wrong person. Sabu, where's the breathing coming from? She said the patient's brain dead, they can breathe. Well, how are they breathing? Nothing from the ventilator. You can turn off ventilators, can see it breathe. Mitchell, which part of the brainstem? You're right so far. Huh? No, not the palm. The medulla. The palm responds to the environment. They cannot respond. Medulla breathes 8 to 10 breaths per minute. So when somebody's brain dead, you can take them off ventilator, still breathing 8 to 10. But if you slap them, 8 to 10. Stick with a needle, 8 to 10. That's how you know. They're not alive. That's just normal medullary breathing. You see, before when doctors did not understand that, that's why they end up keeping these people alive for years because they thought they were still alive. They're not alive. That's why they call it vegetative state. They're dead. They're just a vegetable at this point. But that's why they created the criteria. So you, the doctor, don't create another dead body to keep in a ventilator for years because the family is not going to pay that bill and you're going to be stuck with it. Yeah. The longest I've heard of a comatose patient stay alive on a ventilator, 17 years. And then woke up like nothing happened. That's how you know they were alive the whole time. Yeah. Well, when you're comatose, before Affordable Care Act, insurance policies ran out after $2 million. That's only a few months. That's it. Policy gone. Your family would have to declare bankruptcy on your behalf so that the state would have to pick up the bill. So that's what everybody did. Sold off everything they owned, and that you're bankrupt now. The state has to pay for you. The problem is, if you have the nerve to wake back up, the state says, we got a present waiting for you. It's called the bill for 17 years of hospitalization. Poor guy, he died right in front of the cashier, man. I'm sure he said, hell, I should just stay in the coma, man. Can you imagine a bill for 17 years of staying in a nursing home? They actually moved to a nursing home. 17 nursing home bills like anywhere between $40,000 to $50,000 a year. Well, times 17. I mean, oh, come on, millions of dollars plus all the procedures they had to do for him. It was crazy. But anyway, that's the rules. Yes, Anna. The biggest regulator of basic respirations is medulla. The biggest regulator as far as responding to the environment is your pons. It depends on how they phrase the question. Yeah, obtunded to comatose is, somebody who just looks like they're completely out of it. That's obtunded. Once I see that only sensory information is registering, then they're comatose. Yeah, so he's saying opioids. Why is it when somebody's fully intoxicated with opioids, all you see is respiratory rate of 8 to 10? That's because you just put the patient into a coma. Yeah. All right, Gabriel, you have a question?
Yeah, I had a quick question about back when we were discussing COPD and their response to hypoxia. I understand that we shouldn't give them too much oxygen because they'll end up in a coma, but I think I got confused as to what the pathophysiology of the desensitization was actually.
No, it's just the receptors that sense PCO2. They've been firing for years, and yet your CO2 is never falling below 40. One day they just said, I'm done firing, and they become desensitized. That's it. This is like
Okay.
any receptor. Just like
Oh,
you get
'cause-
downregulation when you have too much glucose or too
That
much
makes total
insulin. Why do you
sense.
get insulin resistance? Same thing. If you keep stimulating receptor without giving it time to reset, it'll desensitize on you.
Okay, so they continue to accumulate COPD through the progression of their disease, and they get to a
Yeah.
point where they just don't respond to.
They just
To
don't respond
CO2.
anymore. Correct.
Okay,
Yeah.
that
It's
sounds
only when
good.
you've been following them over years, then you can tell exactly when they've gone to the other side.
That
So
makes
that's
sense. Thank you.
medulla. Yeah, no problem. Pons, response to the environment, locked-in syndrome. We talked about damage to pons. Patient only blinks because the blink center is separate from the pons. Blink once for yes, two for no, whatever. The pons, however, is the most sensitive osmotic shifts. Remember, we talked about the central pontine demyelinolysis. And that's why Solange knows you shouldn't let sodium change any faster than how many milligrams per hour again? Which one? Not 5, Zena. Not 5. Paul. Meha is 0.5. 5 is a big difference. That's 10 times. Be careful. You gotta put a decimal point in there. 0.5 per hour or 10 to 12 per day. And glucose should not change any faster than Adnan. 100 milligrams per hour. Amnesic center, pneumotactic center, I already talked about. Amnesic at the bottom, pneumotactic at the top of the pons. These are breathing patterns. Look at normal. You inhale for half a second, breathe out for half a second. Inhale for half a second, breathe out for half a second. That's normal breathing. Bradypnea, slow breathing. See that? Still half a second, but much slower. Fewer breaths per minute. Okay? Tachypnea, look at that. More breaths per minute. See that? And you already know that tachypnea and dyspnea is how almost every disease presents, so it doesn't really tell me anything. All right, sighing, see that? After you've taken some normal breaths, all of a sudden your PCO2 sensors at the top of your lungs sense the CO2. It means you got a column of carbon dioxide. You need to empty it out. So make sure you empty it out. Apnea, the person just kind of pauses. No inspiratory effort, but minimum 20 seconds with or without bradycardia. Think about premature babies. They have this all the time, right? What's the mechanism? Their brain is not fully wired yet. They were premature, so their brain is not fully wired. So they don't always get the signal to inhale. How can we get them to breathe more? We can put them into a sympathetic state. What drugs do we use, Sandeep? No, not serotonin. Melissa. Central apnea and the premature babies. I gave you guys these drugs. Linian. Not cortisol. Angie. Not epi. Leslie.
Caffeine?
It's called caffeine and theophylline. You guys forgot already. Make sure you keep reviewing this stuff. All you do is put them into a sympathetic tone. Don't we breathe faster in a sympathetic tone? All you do is buying time. And then one day they start going back to all the apnea disappears. That's how you know the brain is fully wired now. And you can stop the drug. Shane Stokes is when you pause. Shane Stokes means your medulla is missing something it needs, like oxygen, glucose, okay? And then Kussmaul breathing. Again, Kussmaul sign is not saying it's the same Dr. Kussmaul, but this is rapid but deep breathing. If you're breathing this deeply, you're trying to blow off CO2. who would want to blow off a lot of CO2, Michael? Why are they blowing off so much CO2? To make up for, yeah, metabolic acidosis. You compensate. So anytime you see Kussmaul breathing, it means they have metabolic acidosis. Okay. And if they have metabolic acidosis, then we have to figure out